Welcome to our section on chronic tubulointerstitial nephritis and acute tubular necrosis. Let's begin. These are the topics we'll discuss in this section. Let's start with chronic tubulointerstitial nephritis. Here's a list of topics we'll discuss for this section, beginning with definition. Chronic interstitial nephritis is defined as the chronic inflammation of the renal interstitium and tubules. It slowly progresses and eventually leads to end-stage renal disease. Chronic interstitial nephritis is commonly associated with long-term use of medications, especially NSAIDs and acetaminophen. Other medications include lithium, antiretroviral drugs like tenofovir and cidofovir, anti-cancer drugs like ifosfamide and cisplatin, immunosuppressants like cyclosporine and tacrolimus, mesalazine, and herbal remedies. Systemic diseases such as multiple myeloma, sickle cell disease, systemic lupus erythematosus, SLE, and Sjogren's syndrome can also lead to chronic interstitial nephritis. Other possible etiologies include heavy metal toxicity, hypercalcemia, hyperuricemia, and hyperoxaluria. The pathophysiology is initiated with various renal insults resulting from the etiologies that we discussed in the previous slides. Renal vasoconstriction, direct toxicity to renal tubular cells, and tubular obstruction are common initial triggers. Renal vasoconstriction leads to hypoperfusion, which results in papillary and tubular ischemia and necrosis. Consequently, the progressive nature of the disease leads to chronic interstitial infiltration by inflammatory cells and fibrosis and scarring of the renal tissue. Eventually, the renal tubules atrophy, with a gradual decline in renal function. Most patients are asymptomatic, but some may develop painless hematuria and colicky flank pain due to papillary necrosis. Hypertension develops later in the disease course due to chronic renal damage. Non-specific symptoms such as malaise and nausea may also be present. Patients with multiple myeloma will present with CRAB findings, which refer to hypercalcemia, renal dysfunction, anemia, and bone pain. Now let's move on to the diagnosis. Urinalysis typically reveals proteinuria, white blood cell casts, and hematuria. Many of these findings can be present in glomerulonephritis as well, but unlike glomerulonephritis, dysmorphic red blood cells or RBC casts are usually not seen in chronic interstitial nephritis as they are a byproduct of glomerular damage. Renal function tests reveal increased BUN and serum creatinine levels. CT scan may reveal shrunken kidneys with bilateral renal papillary calcifications. Renal biopsy is not performed routinely due to non-specific findings. Before I go any further, I'd like to mention that this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of red blood cell casts. Here's an image showing red blood cell casts. Hopefully you can appreciate a tubular cast with numerous biconvex red blood cells. Remember that red blood cell casts are suggestive of glomerular pathology and are only rarely present in tubulointerstitial disorders. The mainstay of treatment is to remove the offending agent. Hypertension can be treated with angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers. Severe cases may require hemodialysis. Underlying causes such as systemic lupus erythematosus and multiple myeloma must be treated. A 75-year-old male presents with a dull, aching bilateral hip pain for the last 4 months. He reports that it seems to extend to his bones and that he has been feeling fatigue during this time period as well. Physical exam shows an ill-appearing male with conjunctival pallor. Lab findings are significant for increased serum BUN and creatinine. Urinalysis shows proteinuria, white blood cell casts, and hematuria. What is the pathophysiology of this patient's kidney injury? This patient most likely has multiple myeloma. We know this from hip pain, fatigue, conjunctival pallor, and kidney injury. Recall the mnemonic CRAB for hypercalcemia, renal failure, anemia, and bone pain. Also recall that in multiple myeloma, light chain immunoglobulins accumulate and precipitate in the distal tubules, forming casts that result in obstruction and kidney injury. A secondary mechanism of injury is due to the direct toxic effects that light chains have on the proximal renal tubules. Here is the microscopic image of myeloma nephropathy under PAS stain. Hopefully you can appreciate these pink PAS-positive hyaline casts in the renal tubules. These are seen in multiple myeloma due to light chain excretion. Now let's move on to our last topic for this section, acute tubular necrosis. Here's a list of topics we'll discuss for this section, starting with definition. Acute tubular necrosis refers to acute kidney injury secondary to ischemic or nephrotoxic tubular injury. It is a major cause of acute kidney injury in hospitalized patients. The major etiology is ischemia, which is seen in the setting of decreased renal blood flow. Hypotension, shock, and sepsis are some of the common causes of decreased renal blood flow. Nephrotoxins such as drugs like vancomycin, aminoglycosides, foscarnet, cidofovir, and cisplatin. Radioiodine contrast, ethylene alcohol, can also induce tubular necrosis. Heme pigment containing proteins, which can come into contact with renal tubule cells during hemoglobinuria as a result of hemolysis or myoglobinuria as a result of muscle injury, can result in acute tubular necrosis as well. Moving on to pathophysiology. Persistent renal hypoperfusion or renal toxicity leads to ischemia and necrosis of renal tubules. Subsequently, tubular damage leads to formation of casts, which get stuck in the lumen, causing tubular obstruction. This results in decreased glomerular filtration rate and thus can induce renal failure. Acute tubular necrosis can be divided into 3 stages. Initiation phase is up to 36 hours of the disease process, which is mainly characterized by a slight decrease in urine output as it takes time to develop significant renal compromise. Maintenance phase occurs within 1 to 3 weeks and is characterized by oliguria and hyperkalemia. And lastly, recovery phase is characterized by polyuria and hypokalemia. We see polyuria and potassium wasting in the recovery phase because GFR normalizes earlier than reepithelialization of tubules, resulting in increased urine production but a lack of reabsorption. Patients may present with a history of fluid loss such as diarrhea, vomiting, bleeding, or sepsis, or history of exposure to nephrotoxic agents. On physical exam, features of hypovolemia like tachycardia, dry mucous membranes, cool peripheral extremities, and decreased skin turgor can be appreciated. These findings aren't due to the tubular damage itself, but rather are associated with low flow states, which predispose patients to acute tubular necrosis. Over time, GFR and tubular obstruction can result in the inability to excrete fluids and can present with signs of volume overload, such as peripheral edema. Diagnosis is based on urinalysis, which reveals muddy brown granular casts. This is a very high-yield finding. Increased fraction excretion of sodium is also an important feature of acute tubular necrosis, as injured tubules can't reabsorb sodium and thus more sodium ends up in the urine. This finding helps differentiate acute tubular necrosis from pre-renal acute kidney injury, which is characterized by a low fractional excretion of sodium due to increased reabsorption of sodium by the intact tubules in response to hypovolemia. Normal BUN/serum creatinine ratio is common in acute tubular necrosis as tubular damage impairs BUN reabsorption. This is in contrast to pre-renal acute kidney injury, where increased BUN reabsorption in response to hypovolemia results in an increased BUN creatinine ratio. This is how muddy brown granular casts look like. The cast is composed of hyaline matrix along with large plasma proteins. Notice the muddy brown color, which is a characteristic feature of acute tubular necrosis. Now let's move on to the treatment. Treating the underlying cause is of utmost priority. This will prevent further tubular injury and provide time for kidneys to heal on their own. Use of nephrotoxic agents must be stopped immediately. Another important point in management is to maintain euvolemia with diuretics in cases of volume overload and intravenous fluids in cases of hypovolemia. Lastly, dialysis is performed in cases refractory to other interventions. Now let's do a final review question. A 68-year-old man presents to the emergency department due to a recent gastrointestinal illness that caused significant vomiting, diarrhea, and decreased oral intake. Vital signs show a heart rate of 120 beats per minute, a respiratory rate of 18, blood pressure of 90/60, a temperature of 98.8 degrees Fahrenheit, and O2 saturation of 97%. Physical exam shows cool extremities, dry mucous membranes, and decreased skin turgor. Urinalysis shows muddy brown granular casts. What additional laboratory finding would also be expected in this patient? A. Hypokalemia. B. Increased FeNA. C. Decreased FeNA. Or D. Increased BUN to creatinine ratio. This 68-year-old man is in the emergency department due to significant hypovolemia caused by vomiting, diarrhea, and decreased oral fluid intake. Vital signs show hypovolemia with tachycardia and hypotension. Physical exam is as expected in hypovolemic state, showing cool extremities, dry mucous membranes, and decreased skin turgor. This patient's hypovolemia leads to decreased renal perfusion and eventually renal ischemia, which then paired with the finding of muddy brown granular casts on urinalysis, points to the diagnosis of acute tubular necrosis. One of the key findings in ATN is an increased fractional excretion of sodium, since the injured tubules cannot effectively resorb sodium. This makes answer choice B the correct answer. Here's a slide reminding us of the diagnostic findings in acute tubular necrosis. Let's discuss the other answer choices. Answer choice A is incorrect because in ATN, only the recovery phase is characterized by hypokalemia and polyuria. This patient most likely is in the initiation phase, characterized by slight decrease in urine output, or the maintenance phase, characterized by oliguria and hyperkalemia. Answer choice C and D are incorrect because these results would point toward a pre-renal acute kidney injury where sodium and BUN are reabsorbed in response to hypovolemia. In acute tubular necrosis, the fractional excretion of sodium will increase and the BUN creatinine ratio will remain normal due to the inability of the tubules to resorb sodium and BUN. And that concludes the section.